So delighted to have Dr. Kelly Parling-Lynch, DO, oncologist at Cancer and Hematology Centers of West Michigan. What a wonderful collaboration for Gilda's Club and within our community here. And we're so glad, Doctor, for your time today and sharing your expertise and your talents with us here at Gilda's. We'll be recording the session. So again, now's a good time if you would like to go off of video or on mute. Now's a good time to do that. And once we get to the end of the presentation, we'll do a little Q&A where we'll come back on our videos and off of mute to have a little questions and answers time. This presentation is brought to us through one of our grants through Cancer Support Community, which is our national affiliate. And we welcome and invite and encourage all of you to go to the evaluation in the chat portion. There's an eval, a link to that. We'll also email that out to you as well. That's part of how we can continue to learn and grow and getting better and better as how we go about our virtual platform here at Gilda's Club. So we encourage each of you to please fill out an evaluation near the end of the portion here. Without further ado, we welcome Dr. Kelly Parling-Lynch, DO.
Thank you. Can you hear me, Lindsay?
We can, yes, thank you.
Great. Well, I appreciate everybody taking time this afternoon. I actually recognize a few faces on the visit windows. So these slides were kindly shared with me, but as I reviewed them, they were very comprehensive and I thought helpful, but there are quite a few of them. So we may move pretty quickly. And at the end, I'm happy to answer any questions you might have. The slides were reviewed by Dr. Carbone earlier this year in April. Next slide. And again, this program was developed by the Cancer Support Community and was generously sponsored by Amgen and Bristol Myers Squibb. And I have no financial relationships or affiliations with either of these businesses. All right, so the overview of this workshop is that we'll go over what is lung cancer, working with us to help care for you during this treatment, understanding the differences between non-small cell and small cell lung cancer, helping manage side effects and living with this disease, and then we'll have time for questions and answers. So once you get the cancer diagnosis, educating yourself, building a team of support around you, and having hope and courage to face this is a great place to start. What is lung cancer? Next slide. This is the second most common cancer in both men and women, and it's the most lethal cancer of both of those. So prostate cancer and breast is more prominent. The two main types are non-small cell and small cell, and all that means is under the microscope, it's how they described what the cells looked like. One was small and one was non-small cell. They used to call them oat cell, the small cell type. Next slide. In the last few years, there's been some new data regarding screening for lung cancer. Before that, it was looking at sputum and chest x-rays, which weren't very good at picking up lung cancer when it was at its earliest stages. So now there's low dose CTs of the chest. If you have family or friends who've been smokers for long periods of time and are over 55, that's typically the age of folk that fit the criteria, similar to having mammograms when you're a woman, colonoscopies. And this hasn't, they're missing people for this screening tool. A lot of people who would qualify are not getting these tests, so. All right, so the most common type of lung cancer is the first type, non-small cell. It makes up about 80% of cancers. And there's three main subtypes: adenocarcinoma, which is the most common, squamous, which is less than 30%, and large cell. While small cell makes up only about 15% of lung cancer, it grows rapidly and often metastasizes more quickly than non-small cell. These two cancers are most predominantly diagnosed in those who've been smokers, but not all patients with lung cancers have been smokers. So next, when you have the cancer diagnosis, working with your healthcare team to get the best care and guidance. The team may include many different doctors, including a medical oncologist. So that's what I do. I give pills that target cancer, IV chemotherapies, and immunotherapy. A surgeon may be involved. Typically, non-small cell is considered a surgical disease if it has not spread. Radiation oncologist, which can be used in either type of cancers. And then we have a plethora of other teammates, including nurses, social workers, financial coordinators, therapists, nutritionists, etc. Communication is important. Respect and listen and earn your trust. The care team should be available to answer your questions. And if you need a different format, like if you're someone that would prefer things in writing or visual drawings, or if you want to tape the visit so that you can listen to it later, those would be important. And you should be able to have your emotional support team. In the land of COVID, it's been very tricky because we're trying to protect people from exposure to a virus, but people with cancer often have multiple people they want present at a visit. So we're trying to employ phones in the rooms and having patients have their cell phone and FaceTime and all that. So second opinions in oncology. So this is a quote from a patient caregiver. If I've learned one thing, it's that when dealing with any chronic disease, you have to be your own best advocate. There were several times that we brought a second opinion to the table. We felt it was better to be armed with information and come with an opinion versus just sitting back and letting someone else make the decisions. And just so you know, second opinions are very common. I often make referrals to patients so that they can have a second opinion. Sometimes it's with a medical oncologist like myself, sometimes a university, sometimes it's with a different specialist. So you should never be fearful of having one. Write your questions down at home. I find this very helpful. Some people handwrite, some people type it up. Bring a friend to listen and take notes. Ask for copies of test results. I typically offer copies to folks, and nowadays many people have portals where they can log in and see their test results. And then please update us about what other medicines you're taking, if you've been to the emergency room, if you've gotten another opinion that we might not be aware of, so that we can have access to the information to help keep us all up to date. So we're going to delve into treatment options. I'm just going to take a little pause. Is there any questions so far? Are we going too fast? Just let me know. Everybody doing okay? All right, I'll assume we're doing good, but please, you can send a little chat in the chat box if you need to.
Thank you, doctor.
Yep. So typically when I meet someone, I go over the biopsy. That's called the diagnosis. Then we do what's called staging with non-small cell and small cell lung cancer. Typically that includes either a CT scan of the chest, abdomen, pelvis, and a bone scan, or a PET CT, and typically brain imaging. The only time I don't do brain imaging with non-small cell or small cell would be if it's super early stage, stage 1. Because these two cancers do often metastasize to the brain. We also find out how someone's overall health is, what other health issues they have, review whether the treatment is for cure, which means getting rid of all the cancer cells, versus palliative, which means we slow it down and try to extend life and decrease suffering if possible. And then discussing the treatments with the different specialists. And often we work together. So even though you might not see me the same day as you see a surgeon or a radiation, I'm often speaking to them about people's cases so that we're all on the same page. Next slide. All right, questions that you might have. What treatment were you offered? Why was it recommended? What are both the short and long-term side effects to expect? How do you know if the treatment's working? We call that restaging. Are there any clinical trials? There are many trials right now that we have for lung cancer once someone typically progresses beyond the first line. What can you do to prepare for your treatment? Should I eat breakfast, take my medicine? Is there anything special I have to do? How do I get a hold of the doctor and the care team if I have questions? We have a phone number and a triage phone tree, as well as the portal. Patients can directly ask questions electronically. And then how do I get help managing the cost of cancer? And again, we have a financial coordinator that reviews the recommended treatment and will review people's insurances to make sure that it's covered. All right, so let's go into the specific type of lung cancer treatment. First, non-small cell. So I've actually never treated stage 0, but I definitely have seen stage 1A to stage 4B. And stage 4 is now split into 2 different sections. We used to just kind of group anyone who had spread of their cancer from the lung to any organ into one group. The spread can be to the liver or the bone or the opposite lung or the brain. And if it's just in the lung, those folks tend to do better clinically. So they now have been given a stage 4A prognosis and staging category, versus 4B means it's more advanced and more organs and often includes things like the brain. So those are the different stages. And before someone has surgery, we typically do staging clinically with a PET scan and a brain scan. So if someone has stage 1 or 2 lung cancer and it's non-small cell, surgery is considered the standard of care. Now, some people might have early stage lung cancer, but they have a bad heart. They've had a heart attack, or their lung function is very poor. So they have something called emphysema or COPD. And if someone is oxygen dependent, they can't always have their entire lung removed. So even if a person has surgically operable disease, they may not necessarily be a surgical candidate. So that's when I often get in. Chemotherapy and radiation, when used together in stage 3 disease, can actually cure patients. And if you have stage 4 disease, surgery and radiation are reserved for certain situations, but that's considered incurable. And we use immunotherapy, chemo, and targeted agents. And we've had a lot of changes in the last 12 years with non-small cell lung cancer. I've been in practice 20 years, and all we had back then was carboplatin and Taxol and cisplatin and etoposide. Those were the 4 drugs. And now we have so many pills and IVs, and the advent of immunotherapy back in, I think it was November of 2015, has definitely improved the survivorship and the quality of life for people living with non-small cell lung cancer. Next slide. All right, so again, I'm not an expert in surgery, but I've had enough patients be seen by surgeons. And the most common type of surgery for stage 1 or 2 disease is the second one, called a lobectomy. That means you take out the tumor and the healthy lobe that surrounds the cancer. Pneumonectomy means the entire left lung would be out, or the entire right lung. That is a major operation. Again, it's not always needed, but it becomes more tricky if someone has a borderline lung function. But some people can live with just one lung, and some people require oxygen after that kind of surgery, and some don't. A wedge resection typically helps with the diagnosis, but it's not considered curative of an early stage cancer. So if someone can only handle a wedge surgery for, let's say, stage 1 disease, then it would need to be followed by radiation. Similar to when a woman has breast cancer and she has a lumpectomy and they leave behind the breast, but she needs radiation, versus a mastectomy. It's a similar kind of thing. Next slide. Radiation therapy is invisible beams that come from the outside of the body in through the chest to the lung or the brain or wherever the beams might need to be. We can do radiation by itself, or you can combine it with chemo. So we call that concurrent treatment. Let's say someone was not a surgical candidate, but they just had a very small stage 1 lung cancer. Some of them may just have radiation by itself. Or if, I had a guy, he was 89 and this was his only issue, was this small thing. But again, he was not a surgical candidate and he had radiation to the lung. Next slide. Okay. So now we're in the land where I'm at, and there's a lot of names of medications. And so I'll sometimes call this the alphabet soup of oncology. These are different flavors, I guess, of chemo, and they each have different side effects. They kill cells by when it's dividing. So if you remember from biology in high school, when you have mitosis, a cancer cell divides from 1 to 2, and then 2 to 4, and then 4 to 8. And chemo can affect a cell when it's dividing, but it might affect a different part of the cell division. And these different types of chemotherapy target different parts of that. We also sometimes use what we call single agents, one at a time, or more commonly as a combination, like a doublet. Like I'll use a platinum doublet, carboplatin and a pemetrexed, or cisplatin and etoposide. So we call those this is the chemotherapy. These are all the ones listed here are all intravenous. Etoposide does come in a pill form, but we rarely use it that way. Next slide. All right. And this is where it gets very tricky. In the last 7 or so years, we now know that non-small cell lung cancer is not one ubiquitous disease. We knew that adenocarcinoma and squamous acted differently, and we found that different chemos worked differently in them. But then we took it one step further, and in about 20% of non-small cell lung cancer, the tumor itself, not the patient, but the tumor has a mutation. We call that somatic mutation. Germline mutations would be like I was born and I had a gene that set me up for cancer that I inherited from my mom or dad. And so that is a different gene mutation. And some of our patients will test them for both, but most often we're looking at somatic mutations. And we typically run this on a lung biopsy, or if someone had a liver biopsy. And we send these tests out. Often they're run at a third, kind of a higher, a lab that has this type of expertise. One place is called Foundation Medicine. It's in Boston. We use NeoGenomics in California. We use another test called Guardant 360, which is a liquid biopsy. What a liquid biopsy is okay, we did a lung biopsy and it told us it was cancer, but there wasn't enough cells to run one of these mutations that can help us know how to best treat someone. And so with 10 milliliters of a person's blood, you can actually identify if they have one of these mutations. So I'll often be running both a biopsy mutation, and then if that's not helpful, a liquid. And again, adenocarcinoma typically is the one that has the most mutations. The other one that's the hot button item that some of you might have heard is PDL1. It stands for Programmed Death Ligand 1. And basically what it is, there's a substance on the outside of a cancer cell that makes it invisible to your immune system. So it's able to go under the detection of your immune system. So medications like Opdivo, Keytruda, Imfinzi, which is durvalumab, they target the PD-1. They coat the cell with a substance, and then your immune system can see it. And that's the basic premise of immunotherapy. The doctors that helped develop this, I believe in 2016, won the Nobel Prize in Medicine. And we are using the PD-1 agents in many cancers. We're using it in melanoma, kidney cancer, lymphoma. We have a lot of uses now, and it works differently than chemotherapy. The biomarkers, again, it's alphabet soup, but the most common is EGFR, followed by ELK, ROS1, BRAF, RET, MEK, nectar. I have quite a few people who have the EGFR and ALK mutations who are on tablets, so they haven't even had IV chemotherapy at this point. Their cancer is responding to a pill that targets one of those mutations. Now, who should get tested? This slide deck was made in April, and we were doing it on pretty much anybody with stage 4 cancer. But what new data just arose is for people with stage 2, 1B, 2, and 3A non-small cell who have been fully resected. We're running the EGFR now because there's data about a year of a pill called Tagrisso or osimertinib as adjuvant treatment for lung cancer. That's been a major shift in the last 6 months. So fortunately, a lot of my patients have their biopsies done through the Spectrum system in Grand Rapids, and the pathologist, they run all of these standard. I don't even have to ask for them sometimes. So, and then it talks about patients with early stage disease for the biomarker EGFR. Yes, we're doing that. Yep. And then who should get tested? Again, people with more advanced disease. We're trying to get everybody who's going to be treated. So next slide. The biomarker testing is typically done either in the hospital where the biopsy was performed, or the tissue is sent out, or in our office, we can draw the lab test for the liquid biopsies. I don't know if people know, but their tumor that was biopsied, they keep it in wax. They keep a block in the hospital or wherever their storage might be, and they have to keep it for at least 7 years. So if I ever wanted to go back and get testing, let's say 2 years after the fact, sometimes a patient doesn't need to have another biopsy. At that moment, I can go back in time and get the wax block and request those tissue biopsy tests on it. So let's see. And again, in our practice, I work with Dr. Chen, Dr. Santos, and myself. And then there's Dr. Harden out in Muskegon. We're pretty good. They've looked at our data and we're pretty much testing everyone. So when it talks about blood tests missing 30%, when you do tissue biopsy and liquid biopsy, you're pretty much getting anybody who might have a mutation. So they used to call it finding a needle in a haystack, and now it's more like finding a melon in a haystack. You will find it, and we know what to look for now. So it's very important. Next slide. All right, so again, I'm not going to go through every single drug, but some of you might be on some of these medicines, but this is why it's so important to do molecular testing now, because before we just used IV chemo, everybody got it. And now we can say, wait, this person's tumor has this specific mutation. I now can go pick a medicine off the shelf that can be more targeted. So, and I have experience with probably 3/4 of these medicines. The one I haven't used yet is larotrectinib for the NTRK protein. I'm sure it'll happen eventually, but I have used all the rest of them at this point. So, and then the immune therapy I referenced a little earlier. That's the PD-1. And these are some of the names. I didn't use the name Tecentriq, but atezolizumab, durvalumab, and nivolumab, and that word MAB at the end of each one stands for monoclonal antibody. So it's a engineered molecule that teaches your body to fight the cancer. So, and then there's one more, I think on Keytruda would be the next one. And Libtayo, that one is the newest one to the market. I've used that in skin cancer, but now they're using it for non-small. So we have 5 immunotherapies, and you don't typically combine them. You use one or the other. And sometimes it comes down to what the insurance prefers. But in my opinion, as long as you have one, that's good. Now, what you need to know, though, is if you're found to have one of the mutations, let's say EGFR, the immune therapies do not work in them, and there can actually be more side effects. So if you have non-small cell and you're like, why am I not being offered immunotherapy? It could be because you have one of the more targeted mutations, and the immune therapy works best in cancers that are very heterogeneous, or they have a lot of mutations, not just one. So just as a pearl for you to know about. Next slide. All right, so I'll go on to small cell. Again, this makes up about 15%. This also has stage 1, 2, 3, and 4, but the old nomenclature was limited stage versus extensive stage. Limited stage means it's just in one lung, could be in the lymph nodes, but just on one side of the body. Extensive stage means it spread to the other lung or the brain or the liver or the bone. Limited stage is considered curable. Extensive stage is incurable, but both are treatable. Next slide. Surgery, the times I've seen surgery used for small cell is when it was incidentally diagnosed and they had a wedge resection, like for whatever reason, the PET scan showed a spot, but the biopsy was non-diagnostic and the surgeon took it out. If I have a biopsy that knows small cell up front, typically those people get a combination of radiation and chemotherapy. And the most common is cisplatin or carboplatin plus etoposide. That's been the standard for 25, 30 years. But we now are starting to use some immune therapy as well. Now, the laser therapy, I've seen, they're called interventional pulmonologists, where they can go down into the windpipe and they can kind of open up the tumor by just lasering it open. It doesn't really cure the cancer, but it could help someone breathe better if their lung had collapsed or they were having a blockage. So next slide. And then again, the immunotherapy. And then there are other clinical trials going on right now. Next slide. All right, next slide, clinical trials. So everything that we offer patients now in our clinics were based on the shoulders of other patients who've been on a clinical trial and research. And again, 25 years ago, I had platinum doublets and that was about it. And so in our practice, Dr. Chen is probably our most prolific researcher, but I have referred a few of my patients on to him. He has some phase 2 trials, phase 3 trials in Grand Rapids. And then there's something called START Midwest, which looks at more early stage 1, phase 1 trials. That's on the east side of Grand Rapids on Foremost Drive. And Dr. Nahal Lakhani, Dr. Sharma, and Dr. Chandana are in charge of that. So those are bringing compounds that yet are not FDA approved and are going from basically animals to people. And so it's very early stage, but we have both of those options here. So patients often feel that fear of being a guinea pig. In the United States, there's full disclosure on whether or not you get X or Y. You have to be able to be informed. If you're given placebo, it is very clear. Many of the trials that are phase 2 or 3 look at getting the standard of care, and the research arm is the standard plus something like immune therapy or a pill. So people shouldn't feel like they're not getting good care. I actually find that the patients on trial get more closer follow-up and have more attention. So please be open to considering it if you want to consider more treatment and you've exhausted all the standards. So, but we do have those in West Michigan. Let's see. Oh yes, and this is something that I know, but it does not always obvious, is the trials available in our city, Grand Rapids, Holland, Muskegon, are not always what might be available in Chicago or in Ann Arbor or Detroit. So a website that is really helpful, and you're welcome, it's free of charge. It's a government site. It's called clinicaltrials.gov, clinicaltrials.gov. You can type in your cancer, lung, type in EGFR, put your region, and it will give you a listing of all the trials available for your cancer. I find it helpful when someone will bring those to me and say, hey, doc, I saw this. Do you think this might be good for me? And I've learned a lot from patients because there's no way I humanly possible can keep up on all the trials happening outside of my practice. So please, be an advocate and look into those things. And some people want to travel. It might be something only available in New York City or down in Texas, but it's your right to follow those things if you want to, pursue that. And often the clinical trial will pay for the investigational drug. Okay, side effects. This was brought up by one of the people on the call, managing them. In our practice, you can go to the next slide. I'm aware of what side effects can happen. Some of these things that they're explaining here are from the cancer. not the treatment. And it's sometimes tricky to know if it's one or the other, but our nurses, they're called oncology trained nurses, are very good at helping manage these symptoms. But again, nausea, loose stools, changes of appetite, neuropathy, losing your hair, drop of the blood counts, those are the ones that I see the most commonly. Fatigue, trouble breathing, and pain, again, those typically are more from the cancer itself than from the treatment. And obviously anybody going through cancer therapy, it can be overwhelming and anxiety provoking and depressed. So we talk about that at visits as well. Next slide. So I always appreciate when someone has their little calendar or notebook and says, okay, doc, in the last 3 weeks since your last visit, here's what I have. And they tell me on day 3, I had sores on my mouth, and day 5, I had diarrhea. It helps us adjust the treatment so that the next cycle, hopefully it's not quite as toxic. So next slide. All right, so just to throw out this word palliative or palliate, much of what I do as an oncologist is palliative care. That means I give treatments to try to decrease a cancer from hurting somebody. So for example, I met a gentleman today, he has prostate cancer and it's in his bones and it hurts. And so we talked about steroids and painkillers. And then if we start radiation, those are all considered palliative treatments. But the overarching view is some treatments can cure and some can palliate. The word hospice means somebody who's exhausted therapy or doesn't want any further therapy, but is in the last few months of their life, and it's care that they can get at home. So I have a lot of my patients who are on active treatment who are also getting support from the palliative care team. But as time goes on, they can transition to hospice. And what I appreciate out in Holland is our palliative care and hospice team. It's the same people, the same doctors, the same nurses. So patients have built relationships with one team. They don't have to jump ship and get a whole new team for hospice if needed, but it focuses on quality of life. Next. And then living with lung cancer. The universal challenges that people can have is feeling hopeless, that things are out of control, the uncertainty, and feeling alone. So I really appreciate Gilda's Club for setting up a group like this where you can see other folks that are living with this disease. And it can be very isolating, especially the pandemic has added on top of all of that. It's been very anxiety provoking for many patients. So next slide. So some of these emotions can be brought up, some right away, some later. Everyone diagnosed regardless of smoking status is entitled to compassion, the best available treatment. Next slide. We have a emotional distress tool when our folks come in for their visits and to see the nurse and see the doctor so that we can try to find out if they're maybe struggling with some of these things. So, and then trying to focus on some of these things. So having hope and feeling like things are under control. I try my best to give people, I guess, guideposts or touchstones, like when is the next scan? When is the next visit? If this treatment doesn't work, what are you planning, Dr. Lynch? Just to kind of almost give a roadmap for what to expect, because I feel like that takes off some of the burden of worry for folks. And I find that people living with cancer often are very supportive of other people. And when they help each other, then I think it gives them kind of purpose. So. All right, so being straight with your emotions is very helpful. Again, I feel like we're in a time where people are more open, but I do sense that women tend to be more open about their emotions with me. Maybe it's because I'm a woman, I don't know. But men tend to keep things a little more under their shirt, if you will. So we try to be real specific because some people don't even know they might be depressed or anxious. But when we start saying, hey, have you not been able to eat, or is your sleep disturbed? Then they start realizing that, oh, maybe this is affecting me more than I thought. So next slide. So please, if you're struggling with any of these things, reach out, let us know, find a support group like Gilda's, online resources for those tech savvy folks. your clergy or spiritual person, writing a journal. Music is often a balm for people. And there are many mindfulness with, podcasts and calming techniques and, having good mindfulness training. So next slide. And then other ways to take care of yourself, eating well, exercising, trying to sleep as much as possible, pampering yourself, getting a manicure, etc., connecting with others. And then knowing that everyone processes emotions at different speeds. Even in a family, I might have the patient is coping, but the family isn't, but the children don't even, they're angry. People can be in different places. So, but all these are good steps to help yourself. Mm-hmm. All right, so this is another patient named Terry. I'd say as a person who was raised to be independent, that I wasn't accustomed to leaning on anyone. With cancer, you do have to let go. You have to rely on the strength and love of other people. All right, so this, no matter what kind of cancer you may have, and again, my husband and I have done this because we have children, but having a living will, which is a legal document that states what your own wishes are regarding kind of certain things like feeding tubes or resuscitation, as well as designating someone to be your medical power of attorney. Sometimes people have more than one person. Like I have my sister-in-law and my father on, but basically if you couldn't speak for yourself, we're able to see what your wishes were and then reach out to the person that is your power of attorney. And again, some people do that through their lawyer. And in our office, we have social workers that can help folks with this kind of documentation, as well as the financial and then the will itself for your property. All right, and here are some cancer helplines. I actually learned about this. I didn't realize this one, the cancer support helpline. So I put that in my Rolodex. I learned something from the slide deck. And then of course your local resources, your doctors, your nurses, your folks like that. So, yeah.
Wonderful. Thank you. Yes, these can be very helpful resources for folks. And through this grant funded presentation, we're able to share just a little bit more about some of these resources. The Cancer Support Helpline, Open to Options, which can be accessed through Gilda's Club, through the cancer support community. And then of course, what we're doing today here, this educational component to frankly speaking about cancer. Cancer support community, who is a national affiliate for Gilda's Club Grand Rapids, has something called a cancer experience registry. And that's an opportunity for patients to participate in a research survey. And it really targets the better understanding of the emotional and social needs. So it's a helpful way that professionals can learn more about the patient experience, and it's an opportunity. Here's a couple reasons why people and patients would choose to participate in that cancer experience registry. Really gives a voice to your experience as a patient. It's an opportunity for you and your family to speak to some of the issues that are important to the lung cancer community to really help transform the care that we're able to provide. So here's how you may join the registry if that's something that you're interested in. It's cancerexperienceregistry.org. And just a few steps there once you go to cancerexperienceregistry.org to set up your profile. Also taking place through the National Cancer Support Community, of which Gilda's Club Grand Rapids is an affiliate of, is this grassroots movement, again, to really help provide information and key issues that are important to patients with cancer and their families. So it's an opportunity to be a part of a network, interacting with Capitol Hill and policymakers on important issues in the cancer experience. So again, another opportunity to be an advocate and have your voice heard. My Lifeline, that is a great tool through Cancer Support Community that helps provide blogging, a calendar, discussion board, coordinating some care, and you get to manage your privacy settings all in there. So it's a nice interactive tool for patients and their families to help interact with people, that their friends and family or others in the community in a variety of ways. So we wanted you to know that this is something that is available to you, mylifeline.org. Here are some of the resources that, in addition to Gilda's Club Grand Rapids being a free cancer and grief support community right here in our local West Michigan, here are a few resources that might be of interest to you as you do a deeper dive into some of these areas that were presented today. And again, this program was made possible through the charitable grants from MGen, Oncology, and Bristol Myers Squibb. And we're so thankful for the opportunity today.